comorbidities and also some techniques. So respiratory infections is a very broad field. They are one of the most common illnesses any GP or also many doctors in the hospital see every day, especially that time of the year. And I think we can very generally distinguish between upper and lower respiratory tract infections. So upper respiratory tract infections are the common cold, which is usually a rhinosinusitis, so an infection of the nose and the sinuses. Then the pure sinusitis, which is another clinical entity, which has also some other symptoms. Then we go deeper down to the pharynx. Then you can have pharyngitis of tonsillitis, even lower laryngitis, and then also tracheobronchitis. There's a little bit debate about tracheobronchitis because usually the larynx is a little bit the divide between the upper and lower respiratory tract, but because the pathogens and also the pathogenesis between tracheobronchitis, acute tracheobronchitis, and upper respiratory tract infections, they share the same mechanism, so it's usually seen as an upper respiratory infection. And then we have lower respiratory tract infections, which is acute bronchitis, acute exacerbations of other chronic airway diseases such as COPD mainly, community-acquired pneumonia, and nosocomial pneumonia. Of course, there are many others as well, but I think these are for you the most important ones. And I will pick as examples acute exacerbations of COPD and pneumonia to discuss some general mechanisms. Okay, let's start with community-acquired pneumonia. So this is the usual pneumonia people develop while being outside the hospital. And this is why it's called community-acquired. So it's developed outside the hospital during the community. And this is sometimes very tricky because if you see a patient with pneumonia, you never know whether he has been in hospital the last month or 3 months or so. And up to now, it's not very clear where the real cutoff is between community-acquired and hospital-acquired pneumonia. But we usually say that if a patient hasn't been hospitalized for at least 3 months and he's coming from outside the hospital, we would consider this community-acquired. And of course, any pneumonia which is developing during hospital stay, this is of course not community-acquired but hospital-acquired pneumonia. So this is a purely clinical diagnosis, and we talk about diagnosis of respiratory infections. And this is one of the most important points I want to make, is that of course the suspicion of a respiratory infection in nearly all cases of course is clinical diagnosis. So we talk about symptoms, and the most important symptom is probably cough, and this is also why it's here in this definition, which is the definition of the European Respiratory Society. And you need at least one of the following new focal chest signs. So this is when the pulmonary or the doctor does an auscultation of the lung and then hears some abnormal breathing sounds. A prolonged fever more than 4 days, dyspnea or tachypnea, so shortness of breath, and all this without any other obvious cause, because these symptoms, they are not specific. You cannot have the same symptoms with many other diseases. So is there any other obvious cause, then you do not suspect community-acquired pneumonia. But you only can really prove that it is pneumonia if you perform a chest X-ray. So in all these patients where you really have suspected community-acquired pneumonia, if you want to prove it's pneumonia, you need a chest X-ray. Only the chest X-ray will really prove it. But up to now, you see no microbiological techniques, so it's purely starting with a clinical diagnosis. I'm sorry. So how do we do this? Of course, we need to take the history of the patient, about his current complaints, but also know about where he's coming from, what its background is, or what other comorbidities that he has. Then, of course, we'll perform physical examination because there are some signs which are suggestive of pneumonia. Then, point 2, isolation and identification of pathogens. Nearly all guidelines right now recommend not to do this routinely in community-acquired pneumonia. And I will give you some more reasons for this later. So the isolation and identification of pathogens is not what we routinely need to do in these patients if they have an uncomplicated course. And chest X-ray, we need to prove the diagnosis and also to see some other differential diagnosis. Arterial blood gas analysis can help to also to make a obtain some more information about the severity of the disease, because if hypoxemia also develops, then these patients are much more severe than the ones without. And laboratory investigations, they do not really play a big role. Of course, there are some parameters we look at in the bloodstream, like C-reactive protein or leukocytosis, but this is more not important for the diagnosis, but for the follow-up of the patient. So what are the most important signs and symptoms? Already pointed out that cough is the major symptom. 90% of all patients with pneumonia do present with cough. Fever is the second most important probably, and most frequent at least. Dyspnea can develop in 2/3 of patients, and this is also very important. This is mainly related to inflammatory exudates in the alveoli, and that means that if you are short of breath, also the pneumonia is more severe because you have more parts of the lungs are affected. Chest pain can develop every time that the pleura is reached by the inflammatory situation, the inflammatory infiltrate, and this is in around 50% of patients. Tachypnea, yeah, this is also shortness of breath, and of course, for some patients, we try to nail down the etiology, and this can be done by different other things, like asking for the occupation, obviously, whether he has any traveling done, or animal contacts. So, give you a short overview of the clinical presentation. So what do we see as doctors? We can hear over the lungs focal crackles. We can hear a pleural rub if really the pleura is affected. If there is a huge infiltrate, so there is a homogeneous pneumonia developing in one lobe, you can hear bronchial breathing. These are breathing sounds that you really hear the air which is going through the airways. You can have by percussion a dullness, which is suggestive of a pleural effusion, which can also develop. The chest pain can be objectified, and you can see some other symptoms. So, very important, this is mainly clinical diagnosis. And on the basis of the clinical signs and symptoms, we can already give a quite good guess on the possible etiology of the pneumonia. And this is in the end everything, the most important thing you want to do when you're talking about diagnostic techniques. You want to know something about the etiology and all the prognosis. So the etiology we can divide into bacterial pneumonia, the typical pneumonia, which is an alveolar pneumonia. Well, this goes a little bit too much into details for you, I think. And on the other hand, the interstitial pneumonia, which are usually viral or also called atypical pneumonia. So if we have a patient who presents with abrupt onset, so somebody of you is going home and then develops a high fever, some coughing, for example, shortness of breath, that would be an abrupt onset. That can happen. In previously healthy people, as I said, high fever. We see some laboratory parameters which are also suggestive. These patients usually have a productive cough. They have usually a clear infiltrate on the chest X-ray. They can present with thoracic pain, and we'll hear the typical signs over the lungs. So this is a patient with a typical pneumonia, which is bacterial in most instances, and we know that most of the bacterial pneumonia are due to Streptococcus pneumoniae, thus pneumococci. So we can already say, on the basis of this clinical presentation, this is probably a pneumococcal pneumonia. We will treat this patient with penicillin and he'll be fine. If we also have some other indications for other pathogens, I don't go too much into detail there, but we can very clearly distinguish bacterial from viral. And viral pneumonia is usually the patients who have had an upper respiratory tract infection first, a common cold or something, so they have a progressive onset, they're not feeling well since some days, and but they don't present with high fever, they don't have chills, they have different laboratory parameters, they have more a dry cough, so they don't really cough up sputum, and yeah, we'll see on the chest x-rays, sometimes we don't see anything, but sometimes we just see very, very subtle changes. So these are atypical pneumonia, and these are most often viral pneumonias, or in young patients this can also be Mycoplasma pneumonia. We will come across this pathogen later again. Okay, so this is just a short introduction into pneumonia, because I think you need to understand a little bit the disease, of course, and also how we diagnose it. So what kind of diagnostic techniques do we really have in order to learn more about the etiology of the disease, and perhaps also get some information about the prognosis? So we have blood cultures. So for this you need to draw blood, and then this blood will be cultured, as the name says, and then different pathogens can be cultured or not. Of course we can look at the sputum, because it's a respiratory disease, and if patients cough up sputum, we can look at the sputum, we can do the gram staining in order to identify bacteria. And we can also do a culture, and then if there are bacteria, they will probably grow and we can identify them. Then you have possibility to do serology. This is again blood test where you look for antibodies against the different pathogens. But nowadays we also have urinary antigen tests, and they are very elegant tests because you just need a sample of urine, and if patients do have invasive bacterial infection with different bacteria, these antigens of the bacteria will also be found in the urine. So these are very, very good tests we often use. And then at the end, of course, you have a whole array of different nucleic acid amplification tests. That's mainly PCR testing, but can also be others, and they are at the abbreviation NET. So this is the spectrum of diagnostic techniques I want to discuss with you. So give you some information about blood cultures. So I'm not going too much into the techniques because I'm a pulmonary physician, I'm not a microbiologist. But I thought it's interesting for you to know a little bit from how we use these tests and whether they are of any help for us or not. So blood cultures, they have a very high specificity. So that pathogen that is growing in the blood culture, that is the pathogen responsible for the illness. So that is very good. So if we have blood cultures, we are always happy, because then we really know what's going on in the patient. But this is rarely the case, and this is what you see, the sensitivity numbers. So they go up to 30%. Yeah, this is what we say. It's around 20 to 30%. So we're missing 70% of the patients. So if it's positive, it's very helpful, but very often it is not positive. And then it's of course not informative for us. So this is the most important, and it's very sensitive, yeah, for the typical bacteria such as Streptococcus pneumoniae or Haemophilus influenzae, but this is already less. So sensitivity is even going down, but this is also because this pathogen is not as invasive as Streptococcus pneumoniae. So it's most sensitive for the gram-positive cocci. That is perhaps what you can retain. Also Staphylococcus aureus, but Staphylococcus aureus is a pathogen which we do not encounter very frequently in pneumonia. So these are the blood cultures. Then we can have a look at sputum. If patients cough up sputum, it can be helpful, but in fact in the guidelines, in the Dutch guidelines, in the German guidelines, in the European guidelines, it's not really recommended to routinely test sputum in patients with community-acquired pneumonia. But if you have a patient who has a very severe pneumonia, and we can judge this on the basis of some clinical prognostic parameters, this could be this can be advised. And you see here, I just give you a collection of some guidelines here, but this is just an old slide, but I can just go on with this with the newer guidelines. It's a little bit the same. It's a little bit contradictory, and what they say is, okay, if you investigate sputum, you can do a Gram stain. Gram stain is not a very expensive diagnostic technique. You just take the sputum, you need to put the sputum on some slides, then you have the staining, and then you can look at that, and then you can see whether you find any bacteria in there. Probably these bacteria are also the bacteria responsible for the disease. In community-acquired pneumonia, much more so than in exacerbations of COPD, but we'll come to that in a minute. So, this is what it looks like, a Gram stain, and here you see some positive cocci. These are streptococci in this case. And so Gram stain, if it's suggestive of, for example, if you see gram-positive diplococci, then, and you have typical clinical presentation, you are nearly 100% sure that this is pneumococcal pneumonia, and thus you can narrow down your antibiotics to only penicillin, which is a very small spectrum antibiotic, which has many advantages for the patient, but also for community, because you know use of broad spectrum antibiotics also has the problem of that it leads to development of antibiotic resistance in the community and so on. So this is what we always want to do. We want to narrow down the spectrum. So Gram stain can be very informative, and you see some numbers here. So sensitivity and is somewhere between these figures. So you see it's a very broad spectrum again. That has something to do also with the quality of the sputum, because not every patient is able to cough up a real good sputum sample. We have also some quality indicators for that, the number of epithelial cells, the numbers of leukocytes in the sputum. So if you have good quality sputum, the sensitivity is quite high, but this is also a problem that many patients cannot really produce a good sputum. Okay, but if you combine the two techniques together with sputum culture, again, you can increase your sensitivity. But then you talk about sputum culture, and sputum culture, of course, is much more expensive, because you take the sputum, you have to take it to the lab. This has to be cultured for a couple of days. Somebody has to look at the cultures. You need medium and so on. So it's a much longer process, and it's more costly. It is a good technique, and it's relevant for organisms that are not usually part of the normal flora. So if you find a pathogen which is normally not present in you or in healthy people, then you can be very sure that this pathogen probably is also the pathogen responsible for the disease, such as Mycobacterium tuberculosis. We don't see this a lot in the Netherlands, but in other parts of the world this can be a very frequent discovery. Legionella. Legionella is a very virulent bacterium. Legionella, this is why we asked patients whether they had any travel history or whether they have been to a sauna or jacuzzi or something, because Legionella lives in water which has not been heated enough before use. So if you have somewhere warm water installation in an old hotel where the water tanks are not heated above 60 to 65 degrees, Legionella can grow in these water tanks, and then if you take a shower, you just inhale the Legionella, and then you can get a very severe pneumonia. And this is what happens. So we see this, we suspect it quite often in many patients. Then some fungi. Yeah, fungal infections, a very difficult topic, but for some it can be informative. But the usual ones like Candida and Aspergillus, which are present everywhere, this is not helpful. So sputum culture is a good technique, and if you correlate now blood cultures, Gram stain, sputum Gram stain, and sputum cultures, you see that in, at least in these studies I found here, that there is a good there's a good correlation between these three techniques. So you see the most important pathogens, Streptococcus pneumonia, Haemophilus influenzae, and Staph aureus, and you see that most of the patients with positive Gram stain, they also had positive blood cultures, and also the culturizers of the sputum were positive. But as I told you, it is only 40% of the patients really had a valid sputum. So if you look at all patients, then you get completely different numbers. So this is only for patients with a valid sputum sample, of course. So you can identify on the basis of the Gram stain, nearly in many cases, and up to 80% of the cases, you can identify the correct pathogen if you know the epidemiology of the pathogens in your region. So here in the Netherlands, as I told you, it's Streptococcus pneumoniae, which is responsible around 40% of all typical pneumonias. And then the second most important one is probably Mycoplasma pneumonia. This one you will not find with this technique. And then the third one is probably influenza, and then come all the other bacteria. So if you find bacteria, you can be pretty sure it's pneumococcal. Okay, and here in one study they found that the antibiotic choice based on the Gram stain was acceptable in nearly all cases, 95.4%. That is extremely high. Okay, so we talked about Mycoplasma pneumonia. This is a little bit a special pathogen. Has anybody ever heard of this before? Do you have any idea what this is? So you know a little bit that bacteria, they are organisms, they can survive without any other, they can survive on themselves. So they have their own metabolism, they don't need any cells or something to grow in, they just need some sugar and most of them need some air and then some fluid and then they can survive. Okay. Mycoplasma pneumonia is a bacterium that does not have a cell wall. So it's a bacterium that needs human cells in order to survive, in order to replicate, and in order to produce infection. So it's an intracellular bacterium, so without a cell wall. And that is all. And then it's also clear for you that the Gram stain is not helpful because Gram stain is staining the cell wall of the bacteria. And so Gram stain is not helping. It's very difficult, in fact, to really diagnose this pathogen. And what we can do is we can use serology. But what is serology? Serology is you have an infection, then your immune system reacts to this infection, and eventually your B cells will develop some antibodies. It's a long story, so you already appreciate that this is taking some time. So if you're acutely ill and I will draw some blood, I will not find your antibodies because your body hasn't yet produced some antibodies. So you're always late with serology, that's the message. So you always need at least 2 paired serum. You read this here. Paired serum, that means you have an acute serum, so blood taken now and in 2 weeks. And then you can see how the dynamics are of the antibodies, and then after the clinical pneumonia, then you can diagnose the pathogen. So you see, this is the most important problem with serology. So the sensitivity in the first 6 days extremely low. If you wait very long, eventually you will diagnose your Mycoplasma pneumonia, but you cannot wait for this. You have to treat the patient at once. So this is the IgM. These are the acute antibodies, but also IgG. A raise in IgG can be diagnostic, but this is all retrospective. And here you see 2 different studies, one at Leiden and one at Antwerp, and you see that the sensitivity is very low. If it's positive, it's positive. So the specificity is quite good, but in the clinical setting, it's most often not very helpful. And as I told you, Mycoplasma pneumonia, as well as viruses, so all these intracellular pathogens, they have also a different clinical presentation. So if you have a patient with a atypical clinical presentation, you would think of this pathogen probably treated without knowing whether it's present or not. So that brings me to the viruses, because viruses also need cells in order to replicate. So you can compare viruses a little bit to Mycoplasma pneumonia. There are 2 other intracellular bacteria, just to give you the complete picture. There's Chlamydia pneumonia. It's also a pathogen which only survives intracellularly. And Legionella, I already told about Legionella. This is a bacterium with a cell wall, but this is a very special bacterium because it can also infect cells. So it can also really survive in cells. So it can produce atypical or atypical pneumonia. Okay, so these are all these atypicals. And so for viral detection, we're a little bit faced with the same problem. We can use serology, so look for the antibody response, but yeah, it's the same. The sensitivity is maximum 20 to 30%, and it's useful in epidemiological studies and vaccine studies, so for research. It's sometimes useful you know, if you have patients on intensive care or so who are there for a very long time and you find very high titers, then this can be informative. But serology per se is very difficult, and it's not advised to do this in community-acquired pneumonia or lower respiratory tract infections in general. So what else do we have? This is all a little bit disappointing. So we have rapid antigen testing. And that is interesting because it's rapid, and that's what clinicians want. We want to know immediately what's wrong. So we have the urinary antigen tests, and we have other antigen tests. So let's first talk about the urinary antigen tests. There are two different on the market, and they really work, and we use them every day in the clinics, and it's really fine. One is for Legionella pneumophila. So this is a urinary antigen test, so you need a urine monster, and this is immunoassay, in fact, and there are different products on the market, but I think this is from Binax is the one which is most often used. So what you do is you put your urine sample here in this little cart, and then you get you have a control element here. And then if the patient is positive, you will have a second band here. So this has quite good sensitivity. It's around 70%. And you can increase the sensitivity if you concentrate the urine. So if you spin down the urine a little bit, so you take a lot of urine, you spin it down, you have some higher sensitivity. But there are limitations because this test can only detect Legionella pneumophila serotype 1, which is the most common one, and which is present in around 70% of all Legionella infections. And this means that the test is extremely specific and really works very well, but only in clinical practice the sensitivity cannot really be much higher than this, because you just miss the serotypes 2 to 16. They can also be present. And sometimes it takes some time, so what we sometimes do if we have a patient with severe pneumonia, we do the urinary antigen test, and if it's negative and we still suspect the patient has travel history and so on, we just repeat it 1 or 2 days later, and sometimes they can come positive then. So that is that one, and we also have such a test for the detection of pneumococcal pneumonia. It's a little bit the same phenomenon. There's also a certain antigen of the pneumococcus, which you then find in the urine. It's a little bit different technique, but it doesn't matter. In fact, this test has a little bit the same characteristics than the Legionella test. But the question, of course, is pneumococcal. Do you really need this test? It's a good question. There are many studies performed with pneumococcal urinary antigen tests, and well, this is here a very interesting study. So they have had adult CAP patients, 350 patients, and so they had a positive test in nearly 75% in patients with pneumococcal pneumonia, which was confirmed by conventional methods. So you can say the sensitivity was around 75%, but that's an interesting point, and that's also what we see in our own studies, that you also identify a number of patients which were negative with the conventional techniques. So in fact, you identify additional patients, and that is of course very helpful. So unfortunately, you do not find every patient, because there are also many different serotypes of Streptococci and so on. So there are some intrinsic limitations of this test, but I think my feeling is that it's one of the most sensitive tests in general, because you even identify additional patients. Is that clear? Yeah, so these tests, they can really be very helpful. The question, of course, is, do you really need this for your therapeutic decision? And the clear answer is no, we do not, because we know that 40% of all pneumonias are triggered by Streptococcus pneumoniae, and the recommendation is that every patient with pneumonia should receive at least a streptococcal an antibiotic which is acting on the streptococcus. So we always cover Streptococcus pneumonia with our antibiotic technique. So in the end, this will not change really our therapeutic decision in most cases, but in some cases it can, because if you consider some other things, and you say, I want to have a little bit broader coverage for this patient because he's so severe, he has so many comorbidities and so on. So then you could really narrow down your spectrum using this test, and this is also what happens. So sometimes this test can be also inform therapeutic decisions. Here's some more data about this test, and you see that especially this test is very has a very good performance in high-risk patients and patients with bacteremia. So these are also the most severe patients. And if you combine it with a gram stain, then you get a very good result. Okay. So these are the urinary antigen tests, but there are also other antigen tests. And some of you probably know these tests because they have perhaps been performed in you already. Influenza rapid antigen tests, for example, or RSV tests, and so on. So how do they work? So it's quite simple test. What you need is you need a swab, and you put this material also on these little cards, and you have a certain chemical reaction, and then this is also enzyme based assay, and then you'll get these different situations, and you will have a very clear result. They're a little bit less sensitive than other rapid antigen testing techniques, but they're also simpler, which is an advantage. So, and on the market we have, I think, 20 or 30 different tests for influenza rapid detection, respiratory syncytial virus, very important for pediatricians, and you see the different sensitivities here, but the sensitivity is quite good. So if you have, for example, real influenza, this influenza can be proven with such a test. Always it depends on the specimen type, on the what you do, whether you do an aspirate, whether you take a swab or whatsoever. Most of these tests are nowadays performed with flocked swabs. These are very special swab catheters which are not very harmful to the patient, and you get a good sample. You have other techniques. You can also, and this is also performed. This is also a more rapid technique. If you, for example, have sputum of such a patient, and you suspect him to have, for example, influenza, you can also do immunofluorescence-based techniques. And this is just an example you see here. So you see the sputum cells, and then you see in green the positive cells. So you have some labeled antibodies, and then they will bind to the pathogen, and then they can produce some light or some chemical reaction, and then you can differentiate the positive cells from the negative cells. And you see the sensitivity is also very different from test to test, from laboratory to laboratory. But I think there are recent developments that you can estimate that in the future the sensitivity will be quite good. I mean, everybody who ever performed immunofluorescence knows it's a difficult technique, but if you have really an optimized assay in your lab, this can be reliable. You see these figures. So this is another technique you can do. Okay, another important thing to consider looking at these tests is that also patient age plays a role. And there again, you see you can have the optimal test established in your laboratory, but if the sampling is problematic, or the patient is in a special situation, this can really decrease your sensitivities. And you see here in the young patient, if you now compare PCR techniques, which are extremely sensitive, if there is one molecule of the virus somewhere, you will probably pick it up. Virus isolation, which is another technique, it's a little bit comparable to culture techniques, so it's called kind of a virus culture technique, or the ELISA, which here is in these cases is the rapid antigen test. You see that in the young patients, all these tests perform a little bit the same, but the older the patient gets, the less the lower the sensitivity for the immuno-based assays becomes. So this is something you have to take also into account when looking at test results. And the patients I'm caring for, they are about 70 or 80 years. So probably this technique is not very relevant to my patients. And of course, the onset of testing can influence, but you see that it's quite stable over time and even gets better. So the longer you wait, the higher your results. So this can also limit your sensitivity. In the last decade or so, many new pathogens were discovered, and we still think that we only know the tip of the icebergs if we look at the pathogens. Now, new techniques, and we will have another lecture in this series from Professor Sabelkul, I think, who will tell you a bit more about the whole microbiome analysis which you can do. But the point I want to make is that we have always emerging new pathogens. Everybody has heard about the Mexican flu, about bird flu, about SARS, but these are in fact all new pathogens which haven't existed like that before, because otherwise they wouldn't be able to trigger a real pandemic. You can only have a pandemic with a pathogen if there is no immunoprotection in the population. If it's a known pathogen, most of the people already had this infection and there are antibodies, and so you will never get a pandemic. You can get an epidemic, but not a pandemic. So these are some examples. Human metapneumovirus, which was, I think, discovered in 2001. Human coronavirus, SARS, was 2003. You have the human Boca virus, 2005, and so on. And all these are intracellular pathogens, and so it's not very easy to detect them. And I just have this slide here to say to you that with new techniques, with new molecular techniques we are able now to identify new pathogens which we haven't ever seen before. So molecular techniques also play an important role, especially also in the investigation of new pathogens. And what kind of techniques do we have? PCR, polymerase chain reaction, which is really going down to the genome of the pathogens. So it doesn't matter whether they have a cell wall, it doesn't matter whether they are gram-positive or negative, you don't need to culture them, you just need a small segment or some copies of the genome of the pathogen, and then you can amplify this genome, and then you can visualize this on a gel, like here, but you can also, of course, now we have more modern visualization techniques which use some probes which are labeled with some fluorescent markers, and then you can see an increase in fluorescence. You can take this up, and then you have you can even define the quantity of the pathogen. So we have PCRs. Many labs have in-house PCRs, but there are also commercially available PCRs. In-house PCR has the advantage that it's most often much more cheaper than commercially available PCR. The commercially available PCRs, they are extremely optimized, and you have always the same materials which you use, so you don't need a lot of experience in-house, so you can implement this in a lab also with a low level of experience with PCR, for example. So in-house PCRs, you really need to be able to design everything yourself. Then you have single-plex PCRs, which are just looking for one dedicated pathogen. That is also a huge limitation of this technique, because you can only find the virus or the atypical which you are looking for, because you're not growing something on cells where everything grows. Yeah? So the specificity of the primers or the probes you use, this is extremely high, and so this is a major problem of these techniques. And of course, they try to look at very conserved genes where they think these are most often structural genes of the pathogens, where you think of, okay, this must be a little bit the same in all influenza viruses, for example, but especially with influenza, each year we have new strains of influenza, because they change very quickly in their antigenic structure, in their hemagglutinin and neuraminidase proteins, and also in the genes, in their genetic information. So it is very difficult to find the perfect gene, but for some pathogen this has been achieved. For others, they are still busy doing this. So this is a major limitation of PCR. And what you could do is you can have a multiplex PCR. What you use then is you use many different primers, so many different short oligonucleotides, in order to find the genomes of the pathogens, but then you are dealing with problems with cross-reactivity of certain structures. The more oligonucleotides you get into such a reaction, the more problems you get. But there are some multiplex PCRs on the market. There has even been one developed here in Maastricht, which is now used around the world successfully. But yeah, you can have some problems. And then the third one is real-time PCR. I told about that already. So this is the one where you label the oligonucleotide which we use to search the genome with some dyes, and then you can also see the amplification curves, and then you can even compute the viral load. And these are some examples of assays on the market. But you can see these are only some viruses. Yeah? So you're always limited to what your PCR has been designed for. Okay, so the advantages are improved sensitivity. They're really very sensitive. They can even be sometimes oversensitive because you will find everything, and sometimes the results are also not helping you as a clinician. You have quite rapid results. You can have a result in half a day, let's say. With some highly integrated techniques, you can get results in 1 to 2 hours already, and this is the future for sure. And you can have a simultaneous detection, but you can only detect what you're looking for. Disadvantages, yeah, you need a special infrastructure for that. You really need somebody who is able to perform PCR. So skill and expertise do play a role, and some of the tests are still very labor intensive, but now you also have high throughput multiplex PCR with a semi-automated or automated system, so this can be also reduced, and they can be very expensive, of course, because for every virus you're looking for, you need the reaction. In fact, and all this costs money. Okay, so what are now the recommendations? Let's come back a little bit more to the clinics, because I'm a clinician. So what we have in the ERS guidelines, the European Respiratory Society guidelines, is that we say that if a patient is admitted to hospital with fever, we should take blood cultures. That is a standard, which is also performed here in this hospital and many other hospitals. And then it gets much less clear. Sputum for routine gram-staining culture if sputum is purulent and to be correlated with morphotype and gram-stain. So they do not really say perform this, but they say you can do this. The same is true for pleural fluid, for example. You can do testing on that. In serology, you see, it is not recommended for the management. I told you why, because it's a more or less retrospective diagnosis, and this is of no use for a clinician. But it's interesting in the epidemiological studies. The antigen tests, the Legionella test is recommended if you have positive history of travel and so on. The test for pneumococcus pneumonia, it is quite a good performing test, but as I told you, it will rarely inform your clinical decision on which antibiotic to choose. And for the atypical viruses, we talked about this. I think in the future this will mostly be based on PCR techniques, because all the other techniques, they have problems with sensitivity. They are also very labor intensive, and I think PCR is a little bit the upcoming technique. Okay, now let's move to, are there any questions on so far? Okay, let's move to exacerbations of COPD, which is another clinical entity I want to present to you, because it's also very interesting from an infections point of view. So most of the exacerbations of COPD are triggered by viruses. So what is an exacerbation? What is COPD? I think you have heard a lecture already from Louis van Vleteren about COPD, so you know a little bit about COPD and probably also heard about exacerbations. So this is when patients consistently develop more increased symptoms, shortness of breath, more coughing, or change of sputum purulence. So also purely clinical definition, and that is very, very difficult because this is not very specific. But we know that most of them are triggered by respiratory infections. Now, the problem with COPD is, and that has Louis perhaps also told you, that the airways of COPD patients, they are never sterile. In fact, also your airways are not sterile. We just discussed discovered that a couple of years ago that you can detect bacteria also in healthy patients. But if you look at COPD patients, there are really also pathogenic bacteria which are colonizing these patients. This can be Haemophilus influenzae, this can be Pseudomonas aeruginosa, and we also have now good evidence that you also can have latent viral infections in these patients. So it means that even if they are stable, they do not have an exacerbation. If you take a sputum sample, you will find pathogens. Nobody really knows what you need to do with this. Should you try to eradicate these pathogens or not? This is a matter of debate. But what we also do know is if we take PSB cultures. Has anybody an idea what PSB means? This is protected specimen brush. So if you bronchoscope these patients, if you bronchoscope these patients and then you put through your bronchoscope a sterile brush into one of the airways, brush this airway, take this sterile out, and then take it and put it into culture. So a technique which we do not perform every day, but in this study, colleagues from Barcelona, they have done this. And then you see that indeed you will find much higher percentage of positive cultures in the exacerbated patients, but also in the stable ones. And this was a very important finding in this study. So 25% are probably colonized with bacteria. But during exacerbation, you find much more bacteria, much more frequent. Not only much more frequent, but also in a much higher load. So these are the CFU, the colony forming units per ml. You see that they then really have virulent bacterial infection, whereas the colonized patients, you only find a few bacteria, but you find them. So that makes our clinical decision difficult because we do not do PSB cultures, but we just take the sputum. If we find a pathogen, we never know in COPD patients whether this is a colonizing pathogen or a pathogen responsible for the acute exacerbation. So which ones do we find? So here, this is another study which shows a little bit the same. So you have definitely significantly higher bacterial load in exacerbated patients. And so the most important one is Haemophilus influenzae. Haemophilus influenzae is a gram-negative rot, which is a bacterium which belongs to the common flora of the upper respiratory tract. But in COPD patients, this bacterium can go down to the lower airways and can colonize, but also can be responsible for exacerbations. So this is a very important one. Of course, Streptococcus pneumoniae we also find quite frequently, but also in the stable patients. So in this study it didn't come out as a relevant pathogen. Another one is Pseudomonas aeruginosa. This is a problematic pathogen because it's intrinsic drug resistant to the usual antibiotics we use. So we need extra antibiotics for this. And it's also gram-negative Enterobacteria C with the worst prognosis compared to others. And this is also true in ventilated patients. I'll go a little bit faster. So the interesting question is, obviously in COPD patients, they all call off. Many of them are colonized. Can we make any distinction in order to understand a little bit better what is going on? Is it during exacerbation that the same bacterium which is colonizing the airways is then just growing whatsoever much harder, and then is it triggering exacerbation, or is it perhaps something else? In this study, I think it's a landmark study. This study, they used really kind of genotyping of all the bacteria in the COPD patients, and they had a group of COPD patients they were following, and then when they were getting exacerbation, they were handing in new samples. So they had samples from exacerbations, and these are all these arrows, and they also had samples from the stable phase. So they had 14 samples and 3 exacerbations in this patient. And what you can see is that the first exacerbation, they found Haemophilus influenzae, and they said this is this was a certain serotype. And then this patient, at a routine sample, showed another serotype of Haemophilus influenzae and developed an exacerbation. And then again, he showed another serotype and again developed an exacerbation. So our thinking now is that also these exacerbations are triggered by new serotypes. They just belong to the same family. And probably the same is also true for respiratory viruses, but we haven't proven that yet. So you see how this new genomic techniques can really inform also about very important pathophysiological aspects. We lung doctors will always want to have a simple solution for complicated problems, and of course, you know, also in the guidelines and also in the definition of COPD exacerbation, we talk about the sputum purulence. And many colleagues always think, okay, if the sputum is very purulent, there must be bacteria and we need to give antibiotics. And a little bit this is true. This has been shown also again by our Spanish colleagues who love the bronchoscopies. So they had 40 patients, and 20 had exacerbations which were associated with purulent sputum, and 20 had, or 80, had mucoid, so non-colored sputum. And if they then performed their PSB technique, you see that indeed, in the ones with the purulent exacerbation, mostly the culture is positive, so there were bacteria present, whereas in the mucoid, so in the not colored sputum patients, most were negative. So indeed, there seems to be a correlation between sputum color, and the presence of bacteria. And there are other studies. This is an older study which is often referred to, which shows a little bit the same phenomenon. This shows that PMN, these are mononuclear cells in the sputum. In fact, they are nearly 100% of the purulent sputum. They are there, but this is logic because. Why is the sputum colored? This is mainly because of myeloperoxidase, which is an enzyme which is produced by the neutrophils. Otherwise, you don't get the color. Yeah. So the color per se does not inform about, the color does not come from the bacteria, but from the host response from the neutrophils. But you see also in mucous sputum, they are present, many. But when they then look at the Gram stain, it's really that in purulent sputum you find bacteria. And also the cultures are much significantly more often positive, and also with a high bacterial load. So, in fact, sputum color can inform, but it can also mislead you because purulent sputum is just a result of activation of neutrophils, and they can also be activated by viruses. And they didn't look for viruses in this study, so we don't know what the picture is for the viral detection. I would guess that also many viral infections produce purulent sputum. Okay. Atypical pathogens do not play a role in COPD. That was that slide. We'll have to hurry up a little bit. So, what is now the model of bacterial infection in acute exacerbations of COPD? So we think that it's the acquisition of a new bacterial strain against the background of diminished host lung defenses, which is the case probably in COPD, but also this has not been, there's a lot of research to do on there. And also, of course, the pathogen virulence plays a role. But if that comes together, then you can get a change in airway inflammation, an increase in airway inflammation, and then this can either lead to exacerbation or colonization. If you give antibiotics, you can, in some cases, especially during exacerbations, eliminate the infecting strain, but we don't really know to do what the colonizing bacteria, so there's no clinical solution for that yet. Okay, very short about viruses, because now we only talked about bacteria and COPD, but probably more important are viruses. Viruses, they are usually transmitted via droplets, but also hand-to-hand contact. For example, rhinoviruses, the most prevalent one, they are also transmitted via hand-to-hand contact. Every doctor at this hospital is shaking hands with patients every day, so it's an optimal situation for rhinoviruses in hospitals like ours, unless you disinfect your hands. And what is very important about viruses is that the viral shedding, so the real replication of the viruses, is highest before the development of symptoms, the maximum of the symptoms. Of course, you feel a little bit ill, you have a little bit fever, but the maximum symptoms lags behind the viral shedding. So what does that mean? That you can't identify a person who is infected on basis of symptoms, but he will already be able to transmit the virus to somebody else. So it's very tricky with viruses. This is also why they are so successful, because they're only a little piece of genomic information, and that's all that the virus is, with a capsid and some genomic information, and that's a virus. And they can survive. So, and that is because they just jump from one to the others. Not everybody is getting ill, most patients are getting ill, but before they develop symptoms, it's already transmitted to another person. There was a very long debate whether viruses are not only pathogens for the upper respiratory tract, because the common cold, this is the usual cold everybody gets 2 or 3 times per winter, this is triggered by rhinoviruses. And everybody thought, okay, it's only the upper airways and not the lower airways. So there were long debates, but there are many studies really showing, and this is just one study showing you again some immunohistochemistry results where you can see that the rhinovirus really can infect the lower airways. Very important finding. And this is just an example how it looks like after an influenza infection. So here you see healthy respiratory epithelium, all the epithelial cells here with the cilia and so on, different layers, and the subepithelial layers in blue. And after the infection, because the viruses, and in this case it's influenza, needs the cells to replicate. It replicates within the cell, and then when it's released, the cell dies. Yeah, the cell dies, you see here. No respiratory epithelium left. Of course, healthy people can just, you see already here, the replacement takes place from basal cells. But this is how it looks like. And this is also that you can appreciate a little bit what is really going on in these viral infections. And in a patient with chronic obstructive pulmonary disease or asthma, that this can really lead to problems, you can imagine. Okay, so which viruses do we see? What are the most important ones? I already told you, rhinoviruses. This is lower respiratory tract infections in, oh sorry, I thought there was something enough. In general practices. Yeah, and you see that most of the viruses are rhinoviruses, and during the season, which is now, this influenza season starts somewhere in November, let's say, and goes has its maximum somewhere in January, and then goes on until March, April, something like this. So influenza viruses also. These are the most important ones, and the others are less important. So it would be very helpful. I told you about, clinicians always want a simple solution to identify the patients with a virus as compared with a lower a respiratory tract infection SEC as to compare to the bacterial one. If they have pneumonia, you've seen it's more easy. But I'm not talking about pneumonia here. I'm talking just about respiratory infections. And then you see, in fact, that pathogens like rhinovirus and also RSV to a certain extent, they are really producing more of upper respiratory tract symptoms, whereas influenza can also produce lower respiratory tract symptoms. But this is of course also true for bacteria. So it's very difficult you cannot really judge on the clinical presentation in the patient with respiratory tract infection which pathogen is prevalent. So what are the results of the studies? These are the old studies. I call them the old studies because they all use serology, and I told you about serology is not for the patient. There was no benefit, just for you. There's the benefit, and you see that indeed, if you look in exacerbations of COPD or chronic bronchitis, around maximum of 30% of patients were positive. But you also see in serology, it's always also you only find what you look for. So this is just influenza A and the parainfluenza 3, which was tested for. So again, many limitations, but at that time, people really thought that virus infection would play a minor role, and now with the advent of PCR testing, which is the best for viruses, you see that here in this cohort, in outpatients, 40% of patients were positive, and nearly all of them were rhinoviruses. And I think the same was shown for inpatients, hospitalized patients. 56% were positive, but also control patients were positive. And these are the ones that were found in this study, in our study, so rhinoviruses, but also influenza and RSV. And interestingly, if we look at COPD patients, we find viruses more often in the exacerbated patient in the lower respiratory tract. So this is where you expect them. So the best sample to take probably is the samples of the lower respiratory tract. I think we'll stop here. These are some new viruses. This is perhaps even it's interesting just to give an overview over all the studies that have been performed so far. So I think by far the most common virus in exacerbations of COPD are rhinoviruses, followed by influenza and RSV. As I told you, you see that that there are also big differences in different studies, but they come up the highest. Coronaviruses also do play a role. There have been some new coronaviruses found in the last years, and right now there is a new, completely novel coronavirus going on, and the World Health Organization is very interested in this because SARS, you heard about SARS in 2003, was also a coronavirus, a new group. So nobody really knows whether this will be a new SARS pandemic starting up right now at this moment, and some other viruses. Okay, I think we'll stop there. And so to sum up, I think that if you do microbiological assessment of patients with respiratory tract infections, you will really confine this only to patients with lower respiratory tract infections, such as community-acquired pneumonia and exacerbated COPD. In patients with fever, blood cultures should be taken, I told you. In moderate to severe pneumonia, the urinary antigen testing is recommended and really is also informative. As sputum cultures, they are not really recommended routinely, but they can be informative. There is no question about that, especially in severe patients. We tend to do them. And now it's really the era of NAT techniques with all the different issues I told you, and this will probably also change a little bit our view on respiratory infection in the future, but this is the topic of the next speaker in the series. Thanks a lot for your attention.